Hello and welcome to my YouTube channel. My name is Wangoi Mwangi and I'm a Kenyan RN. I do videos on nursing education, patient teaching as well as health education, and this channel is Nursing with Koi, which means I am a nurse and I do practice nursing. The videos I do here, I want to do a disclaimer today. They are not meant for diagnosing anybody with any of these conditions. If by any chance you're experiencing some of the symptoms that I discuss in my videos, please go and see a qualified doctor who can actually diagnose you with that. I do help taking care of patients, and I have a number of clients and patients who are in my YouTube channel as subscribers, and they benefit from the information. So this channel is informative and provides educations about certain diseases, certain cancers, and certain experiences among nurses, because it is also meant to educate nurses so that they can be able to navigate their job as efficiently as they can. So I am not a specialist, I am not a doctor, I am not a self-proclaimed diagnostician. You need to get yourself checked if you are experiencing any of the symptoms, or go to your nearest hospital. When it comes to cancers, most hospitals are equipped to actually refer or treat or diagnose some of these diseases. So if you're in a place where we have a health center or a dispensary, go get checked out. They will refer you to your county referral hospital. And if there is actually something there, they are going to do tests. And if they do confirm this, then you will either be treated there or referred to the referral hospital that has the facilities to treat that kind of disease. So let's dive in and learn about head and neck cancers. And I am not diagnosing anybody. I can't insist on this more than I have. So if you're new here, please take your time to subscribe to my channel and hit the bell icon, and let's learn and keep growing. Thank you. So to understand head and neck cancers, we need to see and actually internalize the anatomy of the head and neck basically. And what we have here, these are the structures found in this area. We do have the hard palate, the nasal cavity, and the oral cavity. If there is any disease in this area, this is still part of the head and neck. Then when it comes to the sinuses, we have the paranasal sinuses, as you can see up here, and also this, if you have cancer of these areas, again will be considered as cancer of head and neck. Then we have the soft palate, again could be affected, the nasopharynx, the palatine tonsils, the oropharynx, the lingotonsils, the hypopharynx, the larynx, the tongue. Salivary glands as well will form a cancer of the head and neck. They're considered part of that. Lips, eyelids, all those are head and neck cancers. So there are many different types of head and neck cancers, but let me not preempt because we are going to see them once we get there. This picture is actually just a small guide to show you and to actually internalize about what we are talking or what we are going to discuss today as a topic. So the most common head and neck cancers are these four, that is nasal cancers or nasopharyngeal cancers, sinus cancers or parasinus cancers, and then or paranasal sinuses cancers. Then we have mouth cancer, oral cavity cancer, buccal cavity cancer, throat cancer, lip cancer, all these areas, salivary gland cancers, the mandibular cancers. All these areas are considered to be head and neck, especially if it either involves the head or the neck area. So let's continue learning. So cancers that are known collectively as head and neck cancers usually begin in the squamous cells that line the moist mucosal surfaces inside the head and neck. For example, inside the mouth, the nose, and the throat. So remember, it has to be those cancers that involves the moist mucosal lining of those areas or surfaces in the head and neck areas, that is in the mouth, the nose, the throat. These squamous cell cancers are often referred to as squamous cell carcinomas of the head and neck, and these cancers also can begin in the salivary glands, but salivary gland cancers are relatively uncommon. Salivary gland contain many different types of cells and can become cancerous. So there are many different types of salivary gland cancers. So cancers of the head and neck are further categorized by the area of the head and neck in which they begin, and these areas are described below and labeled in the image of head and neck cancer regions. Head and neck cancers include heterogeneous glucomalignant tumors arising in all structures cephalad to the clavicle, except for the brain, spinal cord, base of skull, and usually the skin. A meaningful understanding of these malignant tumors requires anatomic separations into those cancers arising in the oral cavity, oropharynx, hypopharynx, larynx, nasal fossa, paranasal sinuses, thyroid, and salivary glands. Cancers arising in the head and neck constitute about 3% of all diagnosed cancers worldwide, but in Kenya, they contribute about 10% of all cancers. So you notice that this number is high, or the percentage is high, and this is largely contributed by the high prevalence of nasopharyngeal cancers in the region. One thing about nasopharyngeal cancers, in short is called NPC, is that it actually affects younger people. You will find people even in their late teenage to middle-aged adults getting these cancers, and they can be quite aggressive. In the year 2007, an estimated 45,500 newly diagnosed cancers of the oral cavity, pharynx, and larynx all resulted in 11,200 deaths. Cigarette smoking and substantial alcohol intake are the major risk factors that are modifiable. About 20% of those who survive cancer of the head and neck cancer will develop another head and neck primary tumor. So in this diagram, we have head and neck cancer cases, percentage distribution by anatomical sites. So when it comes to the gum cancers, we have about 3% being male and 5% being female. So in this diagram, actually what we are learning is that there are more cases in male patients than female patients, but in some areas you will find female patients getting diagnosed with that type of cancer more than their male counterparts. When it comes to lip cancer, about 3% in male, about 3% in female. There is no difference. When it comes to the palate or the hard palate, we have about 4% in male and 6% in female. While in the base of the tongue, we have about 8% in male and about 5.9% in females. Then we have in the tonsillar area, we have 13% in male, 10% in females, while in the tongue we have about 11% male and 17% female. In the floor of the mouth, under the tongue, we have 5% male, 5% female, and therefore that part they are balancing per gender. When you go to the accessory sinuses, 2% in female, 2% in male. That is the same for the nasopharynx. While for the nasal cavity and middle ear, we have 2% in male and 4% in female. When we come to the parotid gland, we have 9% in females and 5% in males. While we go to the oropharynx, we have 3% male, 2% female. And in the hypopharynx, we have equal measure of 2%. When you go to the piriform sinus, that is higher in males at 4% and 2% in females. Other unsuspected parts of the mouth, majorly the salivary glands, ill-defined sites in the lips, oral cavity, and pharynx. This is about 14% in women and 8% in male. So alcohol and tobacco are the major risk factors for cancers of the head and neck. All tobacco products, including cigarettes, cigars, pipes, and smokeless tobacco, are linked to the head and neck cancers, except for the salivary gland cancers. Drinking any type of alcohol, such as beer, wine, liquor, also raises the risk of getting cancers of the mouth, throat, voice box. And about 70% of cancers of the oropharynx, which includes the soft palate and the base of the tongue, are linked to the human papillomavirus. And this is usually a sexually contracted disease or transmitted disease. Ultraviolet radiations or UV light exposure, such as exposure to the sun or artificial UV rays like tanning beds, is a major cause of cancer on the lips. Occupational exposures for being exposed to certain substances while on the job can increase the risk of getting cancers of the nasopharynx. Working in the construction, textile, ceramic, logging, and food processing industries can cause people to be exposed to substances such as wood dust, formaldehyde, asbestos, nickel, and other chemicals. Again, these chemicals can be shown to be carcinogenic based on the research that has been found. An infection of Epstein-Barr virus is a cause of infectious mononucleosis and other illnesses can raise the risk of cancers in the nose, behind the nose, and cancers of the salivary glands. Radiation treatments to the head and neck can cause head and neck cancers. About twice as many men as women get head and neck cancers. They are more likely to be diagnosed in people who are over 50 years of age. So when we're talking about prevention of head and neck cancers, remember a video I had done on primary and secondary prevention of cancer. This is very, very important because when it comes to the primary prevention, all those measures that I spoke about when it comes to primary prevention of cancer are important to take care of while trying to avoid head and neck cancers or prevent head and neck cancers. And this will reduce the exposure to carcinogens, and this mainly is by physical exercise, diet, stopping smoking and use of tobacco products, as well as use of sunscreen before you go to the sun. When it comes to secondary prevention, here it means we need to do a number of tests, and this is colonoscopy, mammography, pap smear, cytology, endoscopy. All those tests that could be used in diagnosing head and neck cancers could be done for the same. And this is to be able to understand the cancer initiation and progression and how to stop it and prevent invasion and metastasis. While tertiary prevention is about adjuvant intervention, targeted therapy, and palliative care. So when we are not able to treat it completely, then we do targeted therapies and eventually we do palliative care followed by terminal care towards the end. So when it comes to signs and symptoms, we have painless masses, local ulceration without pain, referred pain to the teeth or ears, dysphagia or painful swallowing, altered speech, especially blurred words, and an inability to say certain words, persistent hoarseness in voice, unilateral tonsillar enlargement, that is having one enlarged tonsils on one side but not on the other side, persistent unilateral sinusitis, especially that blockage and the way you feel when you have sinusitis, and then persistent unilateral nosebleed or obstruction, unilateral hearing loss, and cranial nerve pulses, as well as loosening of teeth. So they don't have to all be there, but some of these symptoms could help one question if there is more to this than they are telling us or that meets the eye, and therefore run more tests to see if there is any disease that is significant for treatment initiation. For diagnostic purposes, physical examination and history taking are very important in this, and the findings that should be referred or investigated further include red and white patches of the oral mucosa which persist for more than 3 weeks at any particular site, ulceration of the oral mucosa or oropharynx which persists for more than 3 weeks, oral swellings that persist for more than 3 weeks, unexplained tooth mobility not associated with periodontal disease, pain on swallowing persisting for 3 or more weeks that does not resolve with antibiotics, as well as hoarseness of voice persisting for more than 3 weeks, because sometimes we see some sores, some chancres, whatever it is, and we associate them with the flu or the cold, and therefore if it's something that has not resolved within 3 weeks, it is some time we need to investigate further, because most of the flus and those colds will self-heal even without treatment within the second week. Then number 2, once you notice such sites, biopsies could be used. If the site is probably in the neck region or throat area, then endoscopy could be used and samples for biopsies could be taken during endoscopy. Then endoscopic ultrasound could also help analyze further. Then we have FNA cytology, where nodes have been identified, cysts or whatever that could be FNA'd. Then we have imaging studies that such as CT scan, MRI, PET scans, head and neck x-rays. We do have quite a number of diagnostic tests that could be run depending on the facility and the availability of finances, because again, the client will be required to pay for this. Staging is very essential, especially during determination of the goals of treatment and the treatment strategy. While doing staging, it is also important to do risk assessment, and this I will explain as we go further along. Staging should be based on clinical information, imaging, endoscopy, or information found at surgery, because sometimes before someone is opened up, it is hard to tell exactly how the tumor is until the surgeon has gone in and has opened up the patient. Then they will be able to know whether it's even operable, and if it is, is it all resectable, or is it a debulking kind of surgery where some parts of that tumor will be left. Clinical staging determines the treatment strategy, as I had said before, and blood investigation, including total blood count, kidney function test, liver function test, as well as HIV test, are recommended either as you're planning for treatment of this disease, or even before you consider oncology surgery. The TNM system, or the tumor node metastasis system, is proposed by the AJCC or UICC, is the most frequently used staging system. So we are going to see about this system that is used to stage these cancers. So let's not waste too much time. So remember when we were talking about risk assessments, and when you were talking about the risk factors, we had a number of those risk factors, and the most common ones that kept revolving around these cancers included HPV or human papilloma virus, especially for throat cancer, as well as these ages, the larynx, the hypopharynx, the oropharynx, and the other common and recurring risk factor when it comes to head and neck cancers is smoking history as well as alcohol intake. So this risk assessment is based on two risk factors that then will determine the cancer staging that will be found clinically as well as the prognosis. So when it comes to the cancer type, we are talking about head and neck cancers, and then the HPV etiology. If there is human papilloma virus positive in that client with those tumors, and they do not smoke, or they have not been smoking more than 10 pack years, then it means this is a low risk patient. If this patient is a heavy smoker, that means has smoked over 10 packs in the years, then it means if the staging is either NO or N2A, that is still low risk. But if it is N2B or N3 cancer, then that is intermediate risk, for as long as they have HPV positive and they also smoke. When it comes to HPV negative tumors and they smoke less than 10 pack years, then it means that if they are in stage primary tumor, remember T represents primary tumor, while NO or N whatever represent the nodal parts. So if it is T2 and T3 tumor, that is intermediate risk. So when it is HPV negative tumors, there is more risk associated to them because they have probably nothing to do with infection, but probably to do with other risk factors or etiologies. Then if they also smoke less than 10 pack years, but they have T4 tumor, that is still high risk, even if it is HPV negative. But if they have HIV negative but have been smoking more than 10 pack years, then that is immediately high risk, directly, without question. Looking at the T criteria of the AJCC TNM staging, TX means that the primary tumor cannot be assessed because it's probably non-existent or nobody knows actually that it exists. There are no symptoms at that stage. When it is T0 or TO, there is no evidence of primary tumor anywhere, even with investigations, especially if you are doing the secondary prevention of these cancers. When we have TIS, this is carcinoma in situ, and this means that there is some disease and can be detected. When it comes to T1, this is a very small tumor of less than 2 centimeters in the greatest dimension, and this is a low risk tumor, especially when the patient has HPV positive results. Then T2, tumor greater than 2 centimeters but less than 4 centimeters. So this is still early in the disease, and meaning there could be better outcome, especially with combinations of treatments as we are going to see before. Then T3 is tumor greater than 4 centimeters, while T4 is where we have tumor larger than 4 centimeters and has invaded adjacent structures. And usually this is defined at a specific site. So for example, when we have T4A, tumor has invaded the adjacent structures but is potentially resectable. So for example, we are talking about throat cancer, but the tumor has again invaded the surrounding area, let's say the thyroid or the hypothyroid or the whatever around that neck area. But then this tumor is still resectable, it can be removed entirely, then this is T4A. But where we have tumor invading adjacent structures but is not operable or is not resectable, that is T4B.